Okay, so welcome guys to the session today. Sorry for coming late for the session. And so today we're gonna be starting a new topic, and we'll be talking more about the reproductive system. So um you guys should hold your questions. You can ask in between basically. I'm gonna just explain the most high yield concept for you guys. We'll try and see if we can finish up the embryology as well as the anatomy of the reproductive tract, and let's see how far we can go today. Okay, so I'm going to be sharing my screen. Okay, so this is basically the reproductive system, and we're going to talk about basically how everything starts, like from kind of like the beginning, right? And so today we're going to talk about the reproductive system basically, and we're going to be starting basically with how it all starts, right? How it all starts. How do we get like kind of like um how do we like become from a tiny cell, two cells coming together basically undergoing fertilization, and then becoming, a zygote, and then becoming a blastocyst, from morula to blastocyst and everything that happens in between basically. So So today we're talking about repro. Right. And so basically from this diagram here, it's kind of like self-explanatory. But what I just want you guys to focus more on is this part of the table, right? This part of the table. So there are very key events and very high yield things you need to know. And so the first thing you need to know basically is that in the various weeks, a lot of events happening from the first week after fertilization. So the sperm cell, this is the egg cell, and then the sperm with the long leg, neck, and tail, you know, kind of like penetrates the cell, right? This is, and just to mention, the ovum is the largest cell in the body, right? And so this sperm cell that's gotten from um, the male fertilizes the female's egg, and this forms a zygote, right? Zygote. And so what happens, the series of events are characterized according to the weeks, basically, right? So week one, basically, which is around the week when the fertilization occurs, there are key things you need to know in this week, basically. So on day 6 of the first week, day 6, there's a certain chemical that's being released by the cells that's being fertilized, right? So this cell rapidly divides and undergoes a lot of transformation. The first cells that form, basically, you have the morula. So the morula is kind of like a ball of cells. And then from the morula, you have a blastocyst, right? So a blastocyst basically just means you have a ball of cells, and then a lot of the cells are pushed to the periphery here, and then you have a large amount of cysts here, like kind of like fluid filled cavity, basically. And so these cells have to now kind of like differentiate into an embryo that has a bilaminar layer, right? Bilaminar layer, where you have two cells. You have the epiblast and the hypoblast, right? And then further differentiation, cells from the epiblast migrate. So let me just draw this basically. So you have two layers of cells, the epiblasts, and then you have the hypoblast. And then there's a formation of a primitive streaks that marks the beginning of what we call gastrulation, right? Gastrulation. And that primitive streak that goes all the way down kind of forms like an invagination through which the epiblast migrates inside. So there's a migration of cells on the epiblast into the space between the hypoblast and the epiblast. And this process is known as gastrulation, basically. And here you have the formation of a trilaminar disc, right? So the cell undergoes a trilaminar disc. Why am I driving at this, basically? Because there are some certain cells that are specialized, especially in the blastocyst stage, right? And these cells, some of them are responsible for producing the beta HCG, and which is the key thing that happens on day 6. So the beta HCG, human chorionic gonadotropin, is produced, right? But the levels are not so significant at this point, right? So usually around 1 to 2 weeks after fertilization, you begin to see a significant amount of it in blood. And that's why when you test, when you do a PT for a pregnant woman, you discover that the woman has a positive result, because the PT test is just trying to test the level of a beta HCG. And so you would see it more in the blood first before the urine, right? So the point here is that by day 6, the beta HCG is produced in a certain amount that it is almost recognizable, right? By day 6, the beta HCG is kind of like produced, right? And then by week 2, that is when you have the formation of the bilaminar disc, right? The bilaminar disc. So it becomes the epiblast and the hypoblast, right? And then week 3 is where you have the trilaminar disc. So the trilaminar disc is formed basically in week 3, right? As you can see here, basically. And so one significant thing that happens in week 3 basically is this process called neurulation, right? Neurulation occurs in week 3. So basically what happens? So that epiblast that is formed now, so those, like the primitive streak is here, right? Causes this long invagination of cells here inward, right? Causes invagination of the cells inward, basically, to form the kind of like the mesoderm, right? And at that time, when the cells enter into this place and become complete, the cells here accumulate to form what we call the mesoderm. And then these cells, after migrating, the remnant of these cells form the ectoderm. And the ectoderm gives rise to the skin, the hair follicles. So it gives rise to the skin, hair follicles, you know, hair follicles, the nails, and the likes, right? And this guy gives rise to a lot of organs, the musculoskeletal organs, musculoskeletal system, you know, the musculoskeletal system, basically. So the MSK, you know, gives rise to some part of the, you know, other parts of the organs, muscles, connective tissues, and the like. That's what the mesoderm gives rise to. Now, what am I trying to drive at? These remaining cells here, the ectoderm, there is a kind of like cord-like tissue that arises around the 3rd week after the primitive streaks has done its job. And that cord-like cell is known as the notochord. And what the notochord does is that it secretes this guy, right? And this guy is responsible for the process of neurulation. So basically what happens is that the ectoderm starts to thicken. And when this ectoderm starts thicken, right, it's now formed what we call a neural plate. So the notochord, this is the notochord, upregulates the sonic hedgehog gene that drives the primary production of the central nervous system, right? And so this neural plate that is formed as a result of the thickening from the signals of this sonic hedgehog gene causes this plate to thicken, Not only that, it starts causing this cell to kind of like invaginate inward to form like a neural groove, right? This is now called the neural groove. Right? And then eventually this neural groove becomes deepened, and then the cells around here, there are some cells around this region here at the lateral part of this neural plate called the neural crest cells. I call these cells the kind of like nomadic cells of the CNS, the nomadic cells. So they travel far and wide, and we're going to talk about derivatives of this as we go on, right? And so basically this neurulation process kind of like starts around the 3rd week. So it starts around the 3rd week. That's the most important thing I want you guys to understand. And then the neural tube is formed. So basically these neural crest cells you're seeing here, the ones at the edge here, kind of like do their job. They kind of like migrate away from this neural plate. And what you have left is kind of like something like this. So there's a space here, and then this is the neural tube that's deepened, and then there's a space here. But of course, nature abhors vacuum. Like nature doesn't like vacuum a lot. So what happens basically? The cells here kind of like regenerate and can like cover themselves, as well as extending to this side here and forming a continuum with the neural plates that was taken. And so this guy here no longer becomes the neural plate, it becomes the neural ectoderm. That's it, kind of like covers over it, right? Covers over it. Kind of like cover. So the neural tube is here. And this is what forms the brain and other structures, and forms the CNS and all that. While this neural ectoderm kind of forms like the PNS and the rest, okay? We'll talk about that when we get to neurology, but the various derivatives of the individual parts of this thing. But the point is, so we're covering new reproduction. That's the topic we're covering today. Okay, so let me try and round this up so that we can. So yeah, so that's what happens in week 3. So the neurulation occurs in week 3. This whole process that just started basically happens in week 3. And then week 4 is the week, because these things are kind of like high yield. They put them in an exam, they put in a question for you, and they try to test you whether you know what happens at various stages, right? And so that's what I want to do basically. So week 4 is kind of like how will I put it? I usually call it the week that 4 things are formed. So the heart has 4 chambers. So the heart has 4 chambers. The heart has 4 chambers. So the heart is kind of like formed in the 4th week, right? And then the limbs start budding off from the fetus in the 4th week as well. The limbs start budding off in the 4th week as well. And then another thing you need to know, basically, after this 4th week, this week kind of like marks the beginning of what we call organogenesis, right? Organogenesis. So basically, a pregnant woman has basically the first 3 weeks are kind of like the most delicate weeks of the development of a fetus. So within the first week, or let's say the first 1 to 2 weeks, if a patient who is pregnant takes a medication that is teratogenic, because the first week the cells are rapidly dividing, right? There's no differentiation. All the cells are just rapidly proliferating. They're increasing in their numbers and the number of divisions. So a lot of mitosis is going on here. A lot of mitosis, there's increase in mitosis. And if this patient takes a teratogenic substance, it will affect all the cells and it will halt this process of mitosis. So most often than not, any patient that takes a teratogenic substance or a substance that's very harmful for the fetus within the first week, usually leads to usually an abortive process. It halts the development of the cell, and so the cell is not able to, kind of like continue dividing, and hence the fetus kind of like does not, you know, rapidly divides anymore, and so the cell just dies off, and then the woman expels it within the first 2 weeks, right? Within the first 3 weeks, that's after the first 2 weeks. Now, within week three, what happens now is that the cells are now starting the differentiation process. So if you give a teratogen at that particular point in time within week 3, it's going to affect individual organs. You understand? It's going to affect individual cells that differentiate into certain organs, right? Within the week 8, starting from week 8. So various organs are formed at different week after week 8. So maybe the heart is formed in week 4, the GIT starts in week 4 to week 5. The what do you call it? The renal system starts from around week 6 to week 7, and just like that. So if you give a teratogen around weeks, it's going to affect the structure, the individual structure that is more predominant during that week. So if you give a teratogen around week 3, it's going to affect the neural system more than the cardiac system. If you give it in week 4, it's going to affect the limbs and then the heart. So these are things that you need to know basically when you're dealing with this, right? And then anything after week 10 basically, or week 12 basically, yeah, anything after week 10 basically doesn't really cause structural anomaly, but it kind of like halts the growth. So the organs are formed, they are developing, but they don't grow to their kind of like their adult potential. Let me use that word, right? So they don't get to their adult potential basically. So that's why we're actually talking about this topic, because it's very, very high yield for you to know, right? And when we're talking about teratogens, we'll deal with it basically. And so the week 8, like I said, is the week that you have the genitals being formed. So, but the thing is that you can't tell whether the child is a male or a female, because at week 10, there's a gene known as SRY gene. So let me clean this off. So in week 10, basically, the genitals start forming, but you cannot have sex differentiation at that point. At week 8, the genitals form, but you cannot say, oh, this is a male fetus or it's a female fetus, right? Because the what do you call it? The primitive gonads are not differentiated. So you cannot tell, oh, by week 8 that it's a male or a female. You just have primitive gonads that just develop. It's at week 10 that the earliest form of differentiation happens. And there's a gene that occurs. There's a gene that's responsible for that. You call it XRY gene, right? And this is found on the Y chromosome. So once fertilization occurs, you know the father brings the XY, the mother brings the XX, right? And so the fetus sex is determined mainly by the father, because if the father gives a Y chromosome, the fetus is going to be a male. So genetically speaking, basically, from a biological standpoint, the Y gene is a mutated gene. So everything being equal, we are meant to be females. Let me just put it in that way. Everything being equal, no presence of the Y gene that's a mutated gene, we are all meant to be females. So the Y gene is like the factor that kind of tilts the scale to whether you're a male or a female. And the Y chromosome, the XRY gene is located on this Y chromosome. And what it does is that there are two ducts basically that are there. You have the mesonephric duct, right? And you have the paramesonephric duct, right? And so what it does basically is that when this gene is present, you kind of have like the paramesonephric duct kind of like degrading, right? And then the guy becomes a male. So at week 10, this gene starts expressing itself, and then the earliest form of sex determination can be seen, right? Although you won't still be able to pick it in the ultrasound by doing an ultrasound scan. The best time to do an ultrasound scan to kind of like pick the sex of the fetus is at 15 to 20 weeks. That's when you would you can categorically say, oh, this is a male fetus and this is a female fetus, right? So that's what I wanted to just highlight there. Do we have any questions about this aspect? Are there any questions here? Okay, so
Doctor, at what week did you say you could tell if it's a male or female?
okay, so I said that within the first 8 weeks, the genitals are being formed. At week 8, the genitals are being formed, right? But here's the problem. The primordial genital follicles are being formed at week 8, but there's no differentiation. So you can't really tell if it's a male or it's a female, right? Okay, Elias, you have a question?
Yes, Doc. I just
Yeah.
wanted for you to repeat if you can tell us the four things that you said will happen in the fourth week.
Okay, so in the 4th week, basically, there two things. I usually remember it as kind of like the week of 4, because the structures that develop here, they tend to be 4 in numbers, right? And so the heart and the limbs develop primarily in the 4th week, or they start developing in the 4th week. And so the heart has 4 chambers, and then you have 4 limbs: the left, right, upper limb, and then the left, right, lower limb. So that's what I was just trying to say. I call it the week, the week of 4. So it's the week that the structures that have 4 parts develop, right? That's what I was just trying to say then. Yeah, 4 chambers, 4 limbs. Yeah, yeah. So that's basically what I was just trying to say. So I was answering Dr. Eukaria's question. Okay, so let me repeat what happens in the 3rd week and then the first 3 weeks. Okay, so the first 3 weeks, basically, right? What happens in the first week basically is that there is fertilization, beta ICG is being produced, there's formation of the morula and all that. That's what happens. It's at the morula stage in week 1. So the morula is just like a ball of cells, right? That's what happens in week 1. And then in week 1, there's release of beta ICG. Beta ICG. The cells that are responsible for producing beta ICG are known as the syncytiotrophoblasts, right? The syncytiotrophoblasts. I'm going to explain that more so you can understand it when we get later. It will make more sense when we move ahead. I'll be able to show you guys something, why it's like that. I'll try and explain why it's like that. And then, so the morula differentiates, releases beta ICG, tries to form a blastocyst, right? And that stage is known as blastulation. Now you're going into week 2, right? You're going into week 2. What happens in week 2, basically? There's the formation of a bilaminar disc. So the cells, the morula starts differentiating into 2 parts. It differentiates into an inner cell and then an outer cell. The inner cell are formed kind of like the hypoblast. The ones that are closer to the cyst are the hypoblast. The ones closer to like the wall, the external wall, is the epiblast. That's what happens in week 2. There's formation of the blastocyst, right? And then week 3, when week 3 comes out, what happens in week 3 basically is that there's formation of a trilaminar disc. The trilaminar disc basically means that there's a primitive streak. A primitive streak is like a kind of elevation, within the kind of like the epiblast, or a depression, more sort of. So I call it more like a depression. Sorry. So let me show you guys what I was trying to say. So in week 3, basically, you have a cell known as the epiblast, right? So this is how the embryo looks like in week 3. So there's a primitive streak here, and this primitive streak is what initiates the process of forming a trilaminar disc. The appearance of this primitive streak is known as gastrulation. Gastrulation, right? When the primitive streak appears, it's called gastrulation. That's the process, gastrulation. And so what this primitive streak is kind of like an elevation that depresses, so that cells from the epiblast, so this is the epiblast, and this is the hypoblast. Right? So what happens here is that cells from this kind of like the cells from this epiblast kind of like migrate inward here, right? They're trying to fill the space between the epiblast and the hypoblast. So they fill this space here. The cells fill this space here. That's why I'm putting it like red. And then when that happens, you no longer have a bilaminar disc. You have now, you now have 3 layers. You have a trilaminar disc. And this upper layer now becomes the ectoderm. This middle layer becomes the mesoderm. And then this last layer becomes the endoderm. This layer becomes the endoderm, sorry. This layer becomes the endoderm, right? So that layer becomes the endoderm, basically. So what I was just trying to say, I was just trying to explain what happens in the 3rd week. A further addendum to this is that in that 3rd week, after the primitive streak has been formed, there's a structure that's formed also in the middle of this part here, the mesoderm. And it's known as the notochord. The notochord is like a rim of tissue, a tube of tissue that kind of like induces this overlying ectoderm. So it produces a gene known as sonic hedgehog gene. And this sonic hedgehog gene helps with the expression of signals, sends signals to the cells on the epiblast to kind of like help with the differentiation of this ectoderm into what we call a neural plate. So what it does basically is that the ectoderm, under the signals it's receiving from the notochord, so let me call this NC notochord. Under the signals it's receiving from this notochord, it causes this overlying ectoderm to kind of like thicken. It becomes thicken, like a thickened plate of cells. And that thickened plate of cells is known as a neural plate. And so, not only that, when the plate has thickened enough, the notochord also kind of like sends signals for that neural plate that's been formed to invaginate inward. Okay, so let me show this. So let me just show this so that you guys can understand what I'm trying to say, right? So it kind of like, so what happens here is that you have the neural plate, right? So it kind of causes a kind of like invagination. So there's the cell like kind of goes down, something like this. And it's the notochord that's behind all of the notochord is just like a rod of cell here, right? And it's inducing these guys through the sonic hedgehog gene to like kind of like thicken, right? Induces these guys to thicken. And when they thicken, this invagination occurs, right? And so what happens here is that the invagination now starts getting deeper and deeper, right? Deeper and deeper. But it also causes the cells around the lateral ends here, this lateral ends here, to kind of like pull out, right? And these cells that pull out are known as the neural crest cells. Neural crest cells, right? And so what you now have at that time where these cells pull out is something like this. Now these edges are now free. These 2 edges that are free will now have to close up. And so they will close up like this. And then this part of these cells, this part that's closed up will go down, will go posteriorly. And then the cells will close up. So this is what you have basically. Now this neural plate that has kind of like lost the neural crest cells will no longer be called the neural plate. It will no longer be called the neural plate. It will now be called the neuroectoderm. And this is what gives rise to the PNS and the likes, basically. And this guy here gives rise to the CNS. The CNS, I mean the brain and spinal cord, the PNS, autonomic ganglia, peripheral nerves. That's what I basically mean. And this happens in the 3rd week. That's what I was just trying to highlight. I don't know if that's clear, basically. Okay. So now I was talking about the 4th week, and I said that the 4th week, just think about So I call it the week of 4. So basically, you have 4 limbs and 4 chambers of the heart. So the heart and the limbs starts developing at the 4th week. At the 8th week, the genitalias, that is the primordial genital tubercle, starts coming out at the 8th week. But here's the problem: we don't know what sex the child is. We don't know whether it's a male or it's a female. We can't tell. It's just a primordial follicle, the earliest form that the child is going to have a gonad, basically. It's not telling us what type of gonad that is the child going to have. And so at week 10, the Y chromosome, if it's a guy or it's a boy, starts the week 10, this Y chromosome starts producing this gene here, this SRY gene. And this guy kind of like helps with the degeneration of the part of the genital tubercle that wants to give rise to a female. And then the male, it now kind of like switch sides to become more of a male. So this gene causes kind of like degeneration of the female genital tract so that the male can thrive, right? So that's basically what just happens, basically. And even though that happens, when you do an ultrasound scan, you won't be able to see whether the fetus is a male or a female. You won't be able to know. The only time you'll be able to know basically is at week 15. So at week 15 to 20, that is when you can actually categorically say that, oh yeah, this is a male fetus, or yeah, this is a female fetus. That's what I'm just trying to say over there. I don't know if that makes sense though. I don't know if that makes sense, guys. Okay.
Yeah, it's clear. Thanks.
Yeah. Okay, so the next thing we're going to talk about, this everything I was just saying right now. You can see that the neuroectoderm is here, this is the mesoderm, and then the notochord comes in, kind of like tells these guys to like thicken, and then it thickens, it forms the tube. This guy now becomes the neuroectoderm cells. And so the surface ectoderm is the one that gives rise to basically every other thing, which is the neuroectoderm, basically gives rise to the PNS, the peripheral nerves, and all those stuffs, right? So that's what we're talking about here. So and then this is the ectoderm. The ectoderm gives rise to the skin and the hair follicles. The neuroectoderm is the one that gives rise to the PNS and all that. The neural tube basically is what gives rise to the CNS, right? Anything that has to do with the CNS. The neural crest cells basically gives rise to, I think, 9 structures. And how I want you guys to remember this is like the mnemonics, right? MOPAS. But that's not just the thing, because sometimes it can be difficult to remember that mnemonics, right? So I want you guys to think about certain organs that you should remember, right? There are some organs that I want you guys to kind of like remember. So I want you to think of the brain. There are 3 organs that the neural crest cells contributes to. So 1 is the brain, 2 is the heart, and then 3 is the teeth. 3 is the teeth. So I want you guys to think, anytime you think of neural crest cells, right? Anytime you think of neural crest cells and you're seeing a question, what's these cells that participate that, may I just put a question, the derivative of these cells, the neural crest cells, give rise to which of the following structure? So let me put it like that. I think there are 4, not 3. So the skin as well. So think of these 4 structures: the brain, the heart, the tooth, and the skin. So these are like the 4 structures that the neural tube kind of contributes to. And if you look at that mnemonics that I just said right now, you can see that we have derivatives for each and every one of these cells, right? So from here, you have like the PNS ganglia, right? Here we have the skull bone, and then we have we have the Schwann cells, right? The Schwann cells, right? I don't know if that makes sense, guys. And then in the heart here, we have the aorticopulmonary septum. And then here we have the odontoblasts. So that's how I remember it, and it kind of like makes it easy for me. And then the skin, we have melanocytes. So I just think about four structures that the brain, the heart, the skin, and the teeth. And when I'm able to remember that, it kind of like makes sense. Then also the heart, you can have the endocardial cushions. So these guys kind of like form the AV septum. There are 9 of them. I don't know if you guys can remind me of anyone. There are 9 of them. So how many have I listed? 1, 2, 3, 4, 5, 6, 7. So there are like 2 more. Can you guys help me with the remaining 2?
Adrenal medulla.
Yes. So yeah. So the adrenal medulla. So the medulla. And then what's the last one? I think there is cell, group of cells. What do you call those cells?
The enterochromaffin cells.
Yeah, enterochromaffin cells. Yeah. So what you do to make it easy for you is that the enterochromaffin cells secrete neuroendocrine secretions, and then I think you can link these two together because the adrenal medulla kind of like produces the norepinephrine, the catecholamines, right? And so the catecholamines kind of like are example of one of those neuroendocrine secretions. So you can link these two together basically, right? You can link these two together to kind of not forget it. And then when you think of the heart has 2, the brain has 3, the teeth has 1, and then this guy has 1, right? To kind of like make it easy for you. So basically what we have here is 3, 2, 1, 1, right? The brain has 3, so brain has 3, the heart has 2, the teeth has 1, right? The skin has 1. So if you can remember it that way, it's kind of easy. Just know that there are 9 in numbers. When you're able to get this first 7, I think the remaining others can be easy. Whatever way you know, that's how I remember it, to make it kind of like easy, right? I don't know if this helps, guys. Does it help in any way? By categorizing it, does it help in any way? Okay, great. And so we move on, right? We move on. Right? Okay. So I have a question. Someone's asking a question.
Yes, sir. I just wanted to ask if you could just repeat it one more time for the different classifications.
Okay, so I was talking about the neural crest cells, right? The neural crest cells. So let me go back to this. So I was talking about the neural crest cells, right? I was talking about the neural crest cells. So what I was trying to explain here, basically, by these neural crest cells is that anytime I think about the neural crest cells, the first thing I tell myself is that there are 9 in numbers. There are 9 derivatives of the neural crest cells. There are 9 of them. So you have 9 derivatives. So what I do basically in my mind is that I know that there are 4 major organs that I can remember. So if I'm able to remember those organs, I can remember the cells that kind of like are gotten from the neural crest cells. And so what I do is that I write the brain, I write the heart, I write the tooth, and then I write the skin. The tooth and the skin is very much easy to remember. So that takes out 2 out of the 9, right? So the melanocytes and the odontoblasts, very easy to remember. Those ones are very, very important. I can just remember those ones easily. And then I go to the heart that has 2 structures that derive from neural crest cells. And this is the AP septum. We call it the aorticopulmonary septum, and then the endocardial cushions. So basically, I just remember things that form like barriers in the heart, things that can form barriers in the heart, right? It's how I remember these heart structures that have derived from the neural crest cells. So if you think of it, the endocardial cushions are responsible for forming the AV valves, right? And then you have the aorticopulmonary septum that kind of like separates the outlet tract of the heart, right? Kind of like divides the truncus arteriosus into 2 parts, right? So basically, I remember the heart in a way that the neural crest cells that go to the heart help to form barriers. I just think about the 2 barriers that we have: the AV septum, kind of like the AV septum, the endocardial cushions, and then the aorticopulmonary septum. Those are the 2 ways I remember for the heart. For the brain, I just remember the Schwann cells, I remember the PNS ganglia, and then I remember the skull bones. So if I'm able to remember the 7, it's a lot more easier for me to remember the 2 that are not there. I can just think of the adrenal medulla. And one of the cells you can find in the adrenal medulla, the neuroendocrine cells or the enterochromaffin cells. And so it kind of like makes sense. You're able to kind of like picture and easily get derivatives, because these things are high yield in the exam. They test them a lot. The neural crest cell derivatives, they test them a lot. It's very high yield in the exam. So you need to know the 7 of them. First aid gives a mnemonic known as MO pass. MO passes. And so if you're very good at remembering things, you can just cram these mnemonics. The E stands for the enterochromaffin cells, right? The M stands for melanocytes. The O stands for endothelioblasts. The P stands for the PNS ganglia. The A stands for the adrenal medulla. The S stands for the Schwann cells. The S here stands for the septum, which is the arteriocoronary septum. The E stands for the what do you call it now? What will I use now? The S stands for the schwannoma. The E, I don't know what that stands for, though. So I'm not so good at cramming. That's why I just use this basically.
That's
Yes,
the endocardial.
endocardial cushion. Yeah. So I'm not so good at cramming. I just write this out and I'm able to just kind of like remember, right? So you can use either of them. You can write these structures out, that just this heart, brain, skin, and tooth, and then you can just figure it out, or you can just use these mnemonics. Either one works. It depends on the one you like, basically. If you like mnemonics, yeah, sure, go ahead. But me, I just like outlining them. Makes it more easier for me, right? Okay. Does that make sense, guys? Okay, so we are going to talk about teratogens. That's the next thing we're going to talk about. Some are very high yield, some are not very high yield. So I'm going to ask you guys, and you guys are going to tell me what each of them leads to, basically. So I have a patient who's pregnant the first 3 weeks, right? And then I give the patient lisinopril to control the patient's BP. What do you think the patient will come down with? Lisinopril. What would you think the patient will come down with?
They can
We
cause
have kidney problems.
Kidney problems. So yeah. So the patients can have kidney problems, can lead to portal sequence. Yeah.
Or dry cough as well.
Yeah. True. That's a side effect of this drug on the mother. That's more on the mother. But for the child in the womb, the patient will have renal agenesis. So the kidneys won't form properly. And so what do alkylating agents do? You guys are the ones that are going to tell me this. I'm just going to talk about the high yield ones that are very common. Alkylating agents, what do they do? Can anybody tell me? Right? Alkylating agents.
ear deformities,
Yes, the absence of the digits.
Yeah, so limb deformities basically are very key, right? And so what does methotrexate do?
Neural tube defect.
Neural tube
Because
defect.
yeah,
So what does tetracycline do? Tetracycline, what does it do?
Teeth abnormality.
So what about fluoroquinolone? What does fluoroquinolone do?
Cartilage abnormality.
Cartilage abnormality.
Yeah, Achilles tendon.
Okay, great. So what does thalidomide do? This one is very common.
Fibromegaly, limb
Very
abnormality.
baby
Limb.
too, right?
Is
Yeah.
limb abnormality.
Limb has equation.
Okay. So what does let me see which one I'm going to test you guys on now. What does what am I going to ask you guys now? Which am I going to ask you guys? What does isotretinoin do to the body? What does it do to the fetus? Isotretinoin, the anti-acne.
facial abnormality, like cleft palate.
Yeah. So I want to give you guys a mnemonics for the isotretinoin. Just remember the isotretinoin to mean 3 C's. The isotretinoin means 3 C's. I call it the 3 C's, right? I call it the 3 C's. And so the patient has CNS problems, has cardiac problems, and then cleft lip and palate. So that's how I remember it, right? Cleft lip and palate, right? So anytime you think of isotretinoin, just think of the 3 C's: CNS, cardiac, cleft lip, right? Very easy to remember, right? Some people even say it has craniofacial abnormalities. So you can also add that, craniofacial abnormalities, which is where the cleft lip falls under, right? And so you can just remember it that way. It's a lot more easier. The 3 C's: CNS, cardiac, and then craniofacial. Craniofacial, cleft lip. Very easy, guys. Very easy, right? And so you can just have a situation where they tell you that a woman is having acne, that's been having acne, and then she has been taking this medication. She didn't do a pregnancy test, only to find out that 2 weeks later she was pregnant. They can tell you which of the following condition with the patient, with the fetus, be most likely at risk of. They'll tell you renal agenesis. They'll tell you limb aplasia. They might put some other things, and then they might maybe put a CNS or a cardiac malformation or a cleft lip. And so I want you guys to think of it in that way, okay? Okay, so we're going to talk about the other ones, but this is where I want to actually spend a lot of time here to tell you guys about something, right? So I'm going to explain this in a very simple way, right, for you guys to understand. So basically, we have something like this. We have something like this, right? So there are certain disorders or kind of like embryological events that happen to a fetus when a fetus has certain issues, right? Certain kind of problems kind of like arise. And I want to classify it for you. We call it errors in morphogenesis. So I call it errors in morphogenesis. This is very high yield. It comes out a lot. And why? And the good thing about this thing is that I think a lot of you who have done UWorld will see this morphogenesis. So they can be talking about a clinical syndrome or situation, maybe in renal, in respiratory, or whatever. And then they might not tell you, the patient might present with a particular feature, right? And they might not ask you, okay, what error in morphogenesis actually happened in this patient? And so we're going to classify it into two. We're going to classify it into the intrinsic, meaning that it's from the cells themselves. Intrinsic, meaning from the cells themselves. And then we're going to classify it as extrinsic, right? Just follow with me, guys. I want to make it easy for you guys. Just follow me, right? I know it can be a bit confusing, but just follow the story. I just want you guys to get this classification. If you can get this classification, then I think you guys are good, right? So the classification is intrinsic. So the intrinsic problem means basically that the problems are from the cells, right? Are from the cells. The extrinsic means that, okay, it's something outside the cells that's causing the deformity, right? And this way I'm going to just kind of like say something so that it can be a bit easy for you guys, right? So here we go. Let me just explain it for you guys simply. So intrinsic, we have 3 things that you can think of. You can think of agenesis. So you can think of agenesis, right? You can think of aplasia, and you can think of hypoplasia. So what this means is that these 3 conditions are from within the cell. And I'm going to give you guys examples about each and every one of these so that you can have a mental picture of what actually goes on here, right? And then under this intrinsic as well, we can have what we call, you can classify it basically. You can also further classify this intrinsic. So let me also further classify it. You can classify it here as no primordial cells. So no primordial cells. And you can classify this as having, so there's primordial cells. Now I want to further classify this one into any of this. So basically, the agenesis falls into the no primordial cells. I'm going to show you guys a mathematical equation that can help you guys with this. And the primordial cells has these 2, right? Also, you cannot have what we call a malformation, although that's a separate thing we're going to talk about. But let me just classify this for you guys. And then the intrinsic, we just have 2 under it, right? We have a deformation. And then we have a disruption. Right. Okay, so let me now go further and explain this. What do I mean by no primordial cells? So basically, when an organ wants to form, basically, there's a particular cell that comes before all the rest of the cells, kind of like the mother cell. Let me just use that word, the mother cell, right? Or the sentinel cell, the first cell that comes out, right? We call those cells the primordial cells. Those are the cells that not divide and give rise to his brothers and sisters and the likes, right? So basically, if that cell that comes, the sentinel cell comes to, let's say, you have people who are migrating to a new locality, right? And then you have the first person to locate that locality. We give the locality its name. We give the locality its identity, right? So the primordial cells are like that. It's like that guy that comes to a very fresh or virgin land and kind of like colonizes it and then starts having children and gives that land its identity, right? And so what happens basically in agenesis is that that guy that went to that land to kind of like went to that virgin land and tried to like colonize it is not present. He never came. So I want you guys to think about this story like this. Agenesis is a situation where the guy, the primordial guy that gave rise to this land that people are occupying, never came to that land. And so never had kids, never had a wife, never had anything. He didn't even come to the land. So that's how I want you to think about agenesis. So in agenesis, basically, there's no primordial cell. So there's no PC. Right? That's agenesis. And then in patients with aplasia, so what happens here is that the patient has the primordial cells, right? But there is no organ. So this is it. This is aplasia. So I want you guys to picture the guy that came to the virgin land. He came to the virgin land. He occupied the virgin land, but he never got married. He never had a wife. He never had kids. He was the only one that was there. He gave the land its identity, but like there was nobody else apart from him occupying it. So that's how I want you to see aplasia, right? Now for the hypoplasia, I want you guys to see it like this, right? So the guy comes, he gives the land his identity, he marries a wife, but guess what? He couldn't have kids, right? And so I want you guys to see it as, so there's the primordial cells, but what happens? There's partial organ development. And this is hypoplasia. So it means that the opposite will happen basically for hyperplasia. So for hyperplasia, the primordial guy will come to the land. The guy will have a wife. The guy will just start having kids, giving birth to a lot of kids that will give birth to other kids that will now also give birth to other kids, something like that, basically. Do you guys get this illustration at all? Does it make sense at all? Yeah. So basically that's what basically happens with this. So the guy comes in, has a kid, starts giving birth to kids. So it's the opposite. So hyperplasia is the opposite of hypoplasia. For hypoplasia, the guy comes, has a wife, but doesn't have kids. So they're like kind of like underpopulated, right? In that virgin land. But for hypoplasia, the guy comes, has a wife, has kids, those kids have kids, those his kids that have kids, those ones that have kids, something like that, basically, right? Yeah. So for malformation is kind of like different, right? Malformation is kind of like different. So what happens in malformation is that there's a primordial cell, right? But what happens basically is that these primordial cells start kind of like okay, so let me put it like this. The primordial guy comes, he has a wife, right? He has a wife. And then the problem is the children that the guy is having cannot function properly. So the guy comes to the virgin land, gets a wife, has kids, but these kids have a kind of like an abnormality that doesn't allow them to kind of like function properly, right? And so this problem now is intrinsic because it's from his mom and his dad. This problem is from either one of his parents. So there's a primordial guy that comes, has kids, but these kids cannot function. Maybe they can't hear well, maybe they can't see well, maybe they can't do anything basically. And when that happens, basically, you have a malformation. So primordial cell is present, but there's an intrinsic problem in the kids. Intrinsic problem in the like the organ, right? And that's what you have in malformations. Right? Do you guys get malformation? So malformation is like the primordial guy comes, he has a kid, he has a wife, he has a kid, but like the kids are kind of like they have issues. Either they ain't seeing well, or they ain't talking well, or they ain't doing anything well at all. And you get it. And so that's what basically happens in the malformation. So it's more like an intrinsic stuff, right? It's more like an intrinsic stuff. It's not extrinsic per se. It's not outside the cell. It's kind of like intrinsic. So that's why I kind of like talk about it separately so that you can like understand the logic behind it, right? Yeah, and then we go to the extrinsic ones, and then the extrinsic ones are deformation and disruption, right? So what basically happens in deformation, basically, I'm going to use an example for deformation, right? We have a situation of, let's say, Porter sequence. Let me use that word, or let's say oligohydramnios, or let's say, yeah, Porter sequence in a way. So what happens with Porter sequence is that this patient has a problem with the kidneys, right? The guy is not able to kind of like produce urine, and so the patient has oligohydramnios, right? Oligohydramnios. The baby has oligohydramnios, and so the cushion effect that the fetus is supposed to have due to the amniotic fluid is absent, and so the organs of the mom kind of like compresses this guy, kind of like puts a lot of pressure, the stomach, the bowel, the bladder, the liver, and all that. Now, because there's no fluid, the uterus kind of reduces in size, right? Kind of like reduces in size. And so the mass effect of those organs starts compressing this guy that's inside his house, right? Right? And so this guy starts having abnormal defects while he's in his house, right? He's in his house, but still feeling the heat like of the problem, right? Right? And so that's what basically happens with deformation. And then disruption basically is like from the word disrupt, right? This guy has a potential to be like Usain Bolt or LeBron James, right? He has the potential to become those guys. And then he just meets a bad coach that kind of like, instead of encouraging him on, you know, what he's supposed to do, the coach starts giving him exercises that are counterproductive, right? And so this guy doesn't get to like his full potential, right? He's like LeBron James or kind of like Lionel Messi, right? The guy plays football so well. He's able to, you know, dunk, throw a shot from like 30 yards. But like that's what he could do when he was a child. And then all of a sudden, this guy has so much potential to be like the next LeBron James. All of a sudden, he doesn't even start the team. Like he's on the bench, like he's warming the bench and stuff. And so basically, that's what like this disruption is kind of like, basically. So like the guy doesn't like get to that potential of LeBron James level. He's just more like, I don't know. You guys watch basketball. You should tell me of any basketballer that is not like in his prime or something. I don't know. I can for people who watch football or soccer, it make more sense if I say like Marcus Rashford, for example. Like Marcus Rashford, when he came into the youth team, he was killing it, he was scoring goals, giving assists, and then he now met Ten Hag, met Ruben Amorim. Like, what the hell? Like, the guy doesn't even know how to play ball anymore. You understand? So that's how I want you guys to see disruption. Like, the guy had potential when he was 17, 18, and then all of a sudden doesn't really like kind of like make the team anymore, right? Right, and that's what happens. Sequence is just like a situation where one event kind of like affects the development of a particular part of the brain, right? Or a part of a system. So one event comes in, hits a particular, hits the embryo, and multiple organs are involved, right? And so that's basically what happens with that, right? Field defects is more like field defects. The thing is, field defects basically can be more. They're like more like a kind of like malformation. So a field defect and malformation are kind of like similar in a way, but the only problem is that there's no kind of like intrinsic defects, right? There's no intrinsic defect basically. It's more like will I say it's intrinsic? Yeah, I would say it's intrinsic, but the intrinsic is as a result of kind of like not from the cells themselves, but like kind of like external chemicals or genes that are not functioning in certain cells that kind of like causing that process from not happening basically. So I think that's like the simplest way I can kind of explain it. So you guys need to know the example for the steps. They are very, very important for you guys to know, right? So I'm going to talk about the fetal alcohol syndrome basically and kind of like explain what happens, right? So alcohol is kind of like alcohol. Basically, when we're talking about alcohol, we're talking about ethanoic acid or ethanol. So we have C2H5 and O. So this is what we have with alcohol. So this ethanol, when it ferments, it becomes ethanoic acid, right? Ethanoic acid where it becomes CH5. Right? It becomes something like this, right? I don't know if my chemistry is great, right? So it becomes ethanoic acid when it ferments. And this guy here can cross the placenta because it has a hydrophobic part. This part here can cross the placenta, and then it goes to the fetus, right? And so the problem is this guy is kind of very teratogenic for cells. So he kind of like inhibits the growth cycle, the cell cycle. And the problem is that it kind of like inhibits, the cell cycle has 4 phases: G1, you have the S, then you have the G2, you have the G1, you have the S, and then you have the mitosis, and then you have the G2, right? So alcohol inhibits this middle part. That's where the problem is. Alcohol inhibits this middle part of the cell cycle. It inhibits the cells where the proteins are being synthesized, and then inhibits mitosis. So what does it do? If it inhibits mitosis, it means that basically everything will not grow. If it's the skin, it won't grow. If it's the brain, it won't grow. If it's the eye, it won't grow. If it's so I want you to think of fetal alcohol syndrome, that everything basically is small, right? Everything is small because it's affecting mitosis, and if it's affecting mitosis in the cell cycle, there's a halt. The cells are not able to kind of like divide and grow. And of course, it also affects the synthesis phase, meaning that you need synthesis, you need proteins to be synthesized to help with the cell division. And so it affects these two guys here. And when it does that, the cells are small, they can't grow, they can't do anything. And that's what happens in fetal alcohol syndrome, right? And so the patient will present with anything small, microcephaly, small eyes. The patient will present with small nasal bridge. The patient will present with small, smooth philtrum because there's supposed to be a depression there. Yeah, there's supposed to be a depression here, but the place is smooth because the cells are not dividing. And then you have the thin familial border, this stuff here, this stuff at the lower lip here is there's supposed to be an indentation that's kind of like big, that gives you the fine facial features. It's not still working out. Then the vermilion border too is very thin. And these are things that happen, you see in fetal alcohol syndrome, right? You see them in fetal alcohol syndrome. Also, the CNS is affected. The patient's brain is small. The patient can't really do a lot of things. The baby rather can't do a lot of things, right? And then another thing you need to know is that fetal alcohol syndrome is kind of like commoner. It's like, how will I put it now? Fetal alcohol syndrome is worst with a patient with holoprosencephaly, right? I don't know if I murdered that word. I'm sorry, guys. Holoprosencephaly. The fetal alcohol syndrome is worst when it occurs with it, right? It's kind of like bad. It's bad. And we talked about holoprosencephaly as a situation where the neurons fail to migrate. And so basically that part of the brain is like messed up, you know. The cells, the neurons don't migrate. That means you just have connective tissue in the brain, basically. Neuronal migration is important, you know, procephaly, right? It goes there, helps with, you know, differentiation, basically. And if that doesn't happen, then, oh, we're screwed, right? And that's what causes holoprocephaly. So fetal alcohol syndrome is worst when it occurs or causes. It can also cause holoprocephaly. So when it causes holoprocephaly, it's crazy. That's like the most severe form of fetal alcohol syndrome, right? And then the withdrawal syndrome, neonatal, where the patient has this withdrawal syndrome, basically. Neonatal abstinence syndrome this is more common now with opioids. And so basically a mother who abuses opioids in pregnancy, all of a sudden she's like, you know what, I don't want my child to be affected by this my opioid use. And then she kind of like abstains. And then after taking it for a long time, and then maybe it's the second trimester, she decides like, oh well, you know what, shoot, maybe I've kind of like harmed this child. I don't want to take opioids anymore. Suddenly just cuts off opioids, you know, and then when she delivers the child's having kind of funny symptoms, right? So basically what happens is that opioid in excess amounts causes excessive parasympathetic stimulation. And so the baby will be presenting with yawning. When you see that word, yawning, the child is yawning excessively, this is a very high yield stuff for you guys to know. When you see in a question that the child was born and starts having yawning, that word yawning, guys, it's high yield. It's high yield, guys. You cannot unknow this. You must know this. When you see a child yawning, lacrimating, sneezing, right? It is opioid, neonatal opioid abstinence syndrome, until proven otherwise. The mother took opioid in pregnancy and then she stopped. That is like how it goes, basically. And so basically you give them things that will kind of like stop that. So you give them long-acting opioids, methadone, morphine, and generally the US, it's now a recommended thing you do for pregnant women. Like you must screen them for it, right? And so that's basically that. Yeah, and so we're going to talk about the placenta quickly. I want to tell you guys something basically. So the placenta is kind of like the food depot for a child, like. And so the food depots, right? The food depots. So what I want you guys to know basically is that the placenta has two parts, right? It's made up of two parts, basically. It's made up of the fetal part, and then it's made up of the maternal part. The maternal part is mainly contributed by the decidual basalis, right? Right? And then the fetal part is made up of two structures, right? How do I put it now? And then here you have the cytotrophoblasts. So although it's more complex than this, but like this, like the simplest way I can put it, right? And the other part is the syncytial. So first aid gives a very nice way to remember this, right? The cyto means cells, and then the syn here means to synthesize. So excellent. Let's try to understand this basically. The cyto is the part of the fetal component that produces cells that helps to replenish the placenta, to help differentiate cells into various things. The syncytial is the guy that produces hormone, basically. So this is the guy that produces beta HCG. Right? Now, I want to show you guys something, right? I want to show you guys something, just a diagram so that you guys can have a better picture of this, right? So this is the fetal part. This is the fetal part. This is the maternal part. Now, this is the feed up aspect of the placenta. Right? Right? Now, I want to label here as A and B. And I want to ask you guys, which side do you think is the syncytial and which side do you think is the cytotrophoblast? Just a quick question, just to kind of like mentally arouse you guys. So which one do you think will be the syncytotrophoblast and which one do you think will be the cytotrophoblast between A and B? Does anybody have an idea?
B is syncytial trophoblast and A is cytotrophoblast.
Okay, let's assume that is correct. Why do you think it's arranged that way? Why do you think it's arranged that way?
Yeah, because you said that syncytial trophoblast is synthesis the hormones that it can go to the mother's body. So I think that it should be near to mother body. Okay.
Yeah, so Dr. Selva, that is actually very correct. Yeah, so it will not make sense. Like, God is amazing, right? This is syncytial, and this is cyto. The mother has a lot of cells already, so this guy doesn't need to be pumping in cells here, so it won't make sense, right? This is the guy that needs the cells, right? And so this side will be closer to the fetus. The only thing is that this produces hormones, and the mother needs those hormones because, well, God is wonderful. He wants the woman to know that you are pregnant, right? Like, imagine the fetus is receiving the syncytotrophoblast, basically. Like the fetus, like I don't think God wants the fetus to know that he's pregnant, right? So the hormones have to go to the mother so that the mother is aware that, look, you know what, I'm pregnant. Just imagine reverse was the case, right? Reverse was the case. The mother is getting the cells and the fetus is getting the hormones. So it won't really make sense, right? So that's why I think God is amazing and he did it that way, right? So that's why that is very, very important, right? And it's very key that you know that for the steps, right? So that's what we're going to talk about. That's the high yield thing you need to know here, right? These products, you don't need to know that for the steps, you won't be asked. Now, this is a very interesting concept, right? That I want you guys to know. So, twinning is it's a situation where we can have two types of twin. So it's a situation where you have two fetuses, multiple gestation, basically. That's how I can just put it, right? Multiple gestation. Multiple gestation, simple as that. Twinning is just multiple gestation, right? And so before I move on, guys, do we have any questions so far so that I can know where we are? Any questions? Is there any questions or entertain any questions at this point? Do we have any questions, guys? Or should I just go on? Are we getting it? Yeah, so twinning. So basically we have two types of twins. We have dizygotic so what it basically means is that a sperm, two separate sperms are fertilizing two separate kind of like ovums. Zygotic. Monozygotic means, by the way, the monozygotic twins are identical. That's what I want you guys to know. In like 95% of people, it's identical. So what basically you have here is like one sperm fertilizes one egg, and then you have a zygote, right? And then this zygote divides into two cells, two separate cells that go on to divide and form individual blastulas and all of that, right? And so the USMLE step 1 knows that monozygotic twins are identical twins. But the USMLE step 1 wants to tell you whether you know the basic concept of the fact that identical twins can be identical to a very, very certainly high degree. So the step 1 just wants to test whether you know to what extent can an identical twins be truly identical. And so there are two things you need to know, right? There are two things. The monozygotic twins are kind of like identified according to the number of chorions they have and the number of amniotic sac that they have. And so this is the nomenclature that is used to name monozygotic twins. And these monozygotic twins, how identical they would be or they might be depends on the day that the cleavage between the fertilized zygote occurs. So if it occurs within 0 to 4 days, it can occur within 4 to 8 days. It can occur between 8 to 12 days, and then you have greater than 12 days. So if if it occurs within 0 to 4 days, what you're gonna have is a fetus with its own separate chorion, and so we call this di, meaning that it's dichorionic and it's diamniotic if it occurs within 0 to 4 days. And so the cleaved cell will have its own amnion and it will have its own chorion, basically. And then when it occurs on this day, so when it occurs on this day, the fetuses will share one chorion and then have two amniotic sac. And then when it occurs at day 8 to day 12, both the fetuses would have their own individual kind of like, they'll share both their chorion and they'll share both their amnions. And then this is also momo. So it's also, they'll also have their, they'll share everything basically. So for greater than the 12, they share everything. This greater than the 12 is what you see in conjoined twins. So if the division occurs greater than 12 days, you have conjoined twins, which is what Ben Carson worked on, those twins that he worked on. So those twins that he worked on had their cleavage at a day greater than 12 days, right? So what you need to know, basically, the nomenclature is named as in this way. The chorion is named first before the amnion. And so that's basically what you need to know for that. Okay. Do you have any questions at this point? Do you have any questions here? Okay, so I guess the concept's a lot more easier, right? And so we'll go to the next part. And that's basically what happens here. So basically, the umbilical cord has 2 arteries and veins. So basically, 2 arteries and 1 vein. So let me just put it like this. Let me call the artery there 2. Please, there are always 2 arteries. And then there is 1 vein in the umbilical cord that is usually posterior to these 2 guys. So anytime you are thinking of the umbilical cord, I want you to draw a face, right? The 2 eyes are the arteries, and then the mouth is the vein, right? So anytime you are confused in the exams, just draw it draw the face of a person, put the two eyes. Just know that the two eyes are the arteries, and then the smile of the patient, the face is a vein. Very easy way to remember it. I don't even think you need to struggle so much. And so the umbilical artery and the vein are actually derived from the allantois. And then the reason why I'm talking about it is because these allantois kind of like forms, the remnant of these allantois basically is the urachus. And this urachus kind of like degenerates to form the median umbilical ligaments. What you just need to know for the exam is that this guy here carries oxygenated blood to the fetus. And this guy here takes deoxygenated blood, DO2, to the mother. Not only deoxygenated blood, it carries fetal waste and all of that. And so sometimes you can have a situation where this guy just has a single artery and then a single vein, right? And usually that has to do with chromosomal abnormalities. I don't know of any chromosomal disease that has this though. It's not tested in the exam, but you just need to know that something like this exists. So the median umbilical ligament is what this guy becomes. And here's the thing, right? This guy here connects the umbilicus to the bladder. This guy connects the umbilicus, the open here, to the bladder. And so it's supposed to be obliterated. And so what now happens if this guy does not become obliterated? Becomes patent. And that situation is what we call patent urachus. So basically, you have a newborn child, and then when you look at the tummy, 2 days later, the guy starts producing urine. They describe it in the exam as a yellow amber fluid coming from the umbilicus, right? You see the child starts having yellowish discharge from the umbilicus, and they're like, okay, what's the diagnosis? The diagnosis is patent urachus, right? Now, a lot of things can happen to this guy, this urachus, right? And sometimes it can be dilated, right, at this point here. So it might not obliterate, it might be dilated. And in that time, you have what we call a urachal cyst. Right? You can have that. And one last thing you can have is that the bladder the dome of the bladder can kind of form an outpatching into this urachus, right? Into this urachus, and we call that urachal diverticulum. So we call that a urachal diverticulum. Now here's a problem. Here's a problem. Both this cyst over here can gather urine in it, right? And urine basically has to flow out of the body so that there are no microorganisms that will colonize it. Microorganisms. And so these microorganisms basically in this cyst will go there, infect it, and cause a kind of like urinary tract infection for the patient, right? That can go to the bladder and cause issues. Now, what happens when you have a urachal diverticulum, basically? So a urachal diverticulum basically is that the patient, a part of the bladder will kind of herniate into that urachus that is patent. And then that part, basically, most times is the dome. dome of the bladder. And now it's very rare, it's not commonly tested in the exam, but it's a cancer that can arise due to this situation, and it's an adenocarcinoma. So adenocarcinoma of the adenocarcinoma of the dome of the bladder can arise from a patient who has a urachal diverticulum. So I just want you guys to put that at the back of your mind. Now, this situation can also happen in the vitelline duct, right? The vitelline duct connects the midgut to the yolk sac, right? Connects the midgut to the yolk sac. And so you can also have that. You can have a vitelline cyst. You can have a patent vitelline cyst. And so a patent vitelline duct means that the midgut, so the vitelline duct basically connects the umbilicus to the midgut, right? And so if it's patent, the symptoms you see in the child is that meconium will be coming out of the umbilicus. Fecal matter will be coming out, and almost the same thing that happens with the urachal cyst, and then there's a dilatation, and that one you call it a vitelline cyst, vitelline duct cyst. Almost the same pathology I just highlighted earlier on, vitelline duct cyst, right? And then you can also have the what do you call it now? Vitelline diverticulum, which is also known as the Merkel's diverticulum, which is, we'll treat that later in GI, right? Okay. So at this point, are there any questions before we go further? Right? And that's what I just explained here. That's the diagram that's kind of like. Now, the Merkel's diverticulum, let me just add a note on it, is a true diverticulum. So a true diverticulum has 3 layers. All right, it has 3 layers of the tissue that is coming out. So if it's the GI tract, you have the mucosa, you have the submucosa, you have the muscularis mucosa or the muscularis propria, and then you have the adventitia. So it will have those 4 layers, right? But we'll talk about it in the GI more. I'm not going to dwell on it basically. And so we're going to talk about the pharyngeal pouches. So what we're going to talk about here basically is how it's formed basically. And so the pharyngeal apparatus has 3 components, right? It has the pouch, it has the cleft. So let me just arrange it. They call it a cap. And so it's a cap. The pharyngeal apparatus has 3 parts. It has the cleft, it has the arc, and then it has the pouch, right? So this is the this is the ectoderm, this is the mesoderm, and then this right here is the endoderm. Okay. And they have what's kind of like the produced in the fetus, right? Okay. So for today, I'm going to stop here and entertain questions, and then the next class we're going to build from that and go on further, right? So
Dr. Ohis, so how long it will be take time to finish reproductive? Do you have any idea? Like,
if we're fast enough, we can finish it within 4 days. But if we're slow, it might take up to a week. So it depends.
Okay.
Yeah. If you're fast enough, like I go as fast as I can, 4 days. But if I'm slow, a week, a week max. Right? I want to finish it with you guys. I want to finish it with you guys so I can go to GIT. That's what I want to do. So I might be fast some days. Okay, so the yolk sac. Yeah, so I don't know why this my first day doesn't have a diagram so that I can show you guys the yolk sac, right? This is not a very good diagram to illustrate it. Oh God, it's not a very good. I don't have a diagram here that can show. Okay, so let me use this, right? So basically, do you see this thing here? This thing you're seeing here, this thing, this part here, this cycle part here, that's the yolk sac. So that's the yolk sac, basically, this thing you're seeing here. So the fetus has a communication with this yolk sac via that vitelline duct. So this is the yolk sac, right? This is the yolk sac. This thing you're seeing here is the yolk sac. This guy here, this thing you're seeing here is the yolk sac. I don't know if that answers your question, Doc. So we're gonna end today at this point. Tomorrow we're gonna continue. We're gonna go as far as studying pathology tomorrow, and I want you guys to come prepared. This is just like a brief introduction of repro. Do you guys have any questions before I conclude today? Any questions, guys? Okay, so I'm gonna see you guys tomorrow, the same time. We're gonna continue and see how we can go as far as possible. No, I say you. No, I didn't say you guys should. I say you guys should like try and like. We're gonna start from where we stopped and try and finish up to pathology. That's what I'm trying to say. We're gonna get to pathology tomorrow. That's what I'm trying to say. Okay, so take care, guys.